Okay, so you see the, let me do this again. Oh, you're not showing the right screen, hold on.
I think the other way was, there we go. Okay.
What about now? You're
Yeah,
good?
looks good.
All right, so just as for me, for, having a sense of how much Spanish do you all want me to do? Because I can do this whole presentation in Spanish. I can do it 50% in Spanish. I can do it 2% in Spanish. How do you all want me to do? How do
So,
you say 50-50 here, are medium to uh, proficient in Spanish or what?
so I think it's really up to you at the end of the day, but I think a lot of our people that come to our sessions are not fluent in Spanish. So I think the majority should be in English, and you can incorporate some of the Spanish phrases or words into the presentation if that's okay.
Sounds good. All right, well, let's do it. So thank you again so much for inviting me to give this talk. I'm Joel Frontera. I'm a associate professor here at UT Health Houston, Department of PM&R. So I like to give this talk to medical students. It's a talk about the early assessment of a person with a spinal cord injury. Part of my clinical duties is seeing consults in a level 1 trauma center. So I see a lot of the new spinal cord patients that come in. And I also have a chronic spinal cord injury clinic, which I see patients that have a chronic spinal cord injury. So I guess I have a good kind of combination of ways to see patients from a really, really new injury to a chronic injury. Así que vamos a hablar hoy de una evaluación temprana de una persona con trauma al cordón espinal. Y para mí yo estoy agradecido de tener esta oportunidad porque les puedo hablar de como cuando yo hago consultas en un hospital de nivel 1 de trauma y veo pacientes en mi clínica. So I'll be going back and forth in Spanish and English. If that's okay, you guys can stop me. I think I can look at the chat here real quick if you have any questions. You can do them in English or Spanish. You don't need to use Google Translate. Should be okay. So, all right. What are the numbers? ¿Cuáles son los números de esta población, of this population? So we have approximately 54 cases per 1 million people in the United States. That's incidence or incidencia in Spanish. 17,000, almost 18,000 new cases a year. Of new traumatic spinal cord injury, and about 300,000 persons live with a spinal cord injury right now in the U.S. Obviously, it varies for other countries around the world. We don't have very good numbers for Latin America and Puerto Rico. One of my colleagues here, Dr. Hernandez, has a committee in the Asia conference that works a lot with Latin America and are giving education to our Latin American counterparts to kind of spread the word around spinal cord injury, acute and chronic management, which is lacking compared to the U.S. The average age at injury is 45 years old right now, so middle age, give or take, and it's up from 29 years old back in the 70s. And the reason is the population in the US is basically aging. We all know that. That's why we need rehabilitation doctors. That's why we need primary care doctors. And so as the population ages, the type of injury changes as well. This is the National Spinal Cord Injury Statistical Center at the University of Alabama in Birmingham. And basically gives you a lot of data about patients that are admitted in the spinal cord injury model systems. There's about 17 or 18 hospitals that are collectively called model system or sistema modelo that, it collects data about type of injury, age, demographics, causes, and all those things. So as you can see, since 2015, race and ethnicity, about 24% of injuries have occurred among African Americans, which is higher than the population of African Americans in the general population. So minorities are disproportionately getting injured as compared to white Americans or Caucasians. The causes of injury in general, the number one is vehicles, car accidents, motorcycle accidents. Coming in at very close second is falls. And then we have violence, and we got the sports and others, right? But the main two are motor vehicles and falls. Motor vehicles, or accidentes de vehículos de motor, and have been the most common one for a long time. But their proportion compared to falls have sure now it's like a third and a third almost. And this is where the aging population comes in, because our aging population, 60s and over, are falling more. They're falling in the bathtub, they're falling down the stairs. You can't imagine how common it is to fall down the attic while they're cleaning the attic or putting lights or whatever. And so those injuries are becoming incomplete, meaning that they still have some motor control or some sensation, and they are older. So this is where the discrepancy lies. Así que básicamente lo que estamos hablando aquí es de causas de vehículos de motor, y caídas son las principales. Seguido por deportes, seguido por violencia y seguido por deportes. In terms of violence, the most common one will be gunshot wounds. And that's very, unfortunately, in big cities, that's a very common situation on a level 1 trauma center. How's my English-Spanish mix here? We good, or you need more Spanish, or okay?
I think you're doing well.
Okay, just checking. You guys know about this more than I do. This is an older picture about the ascending and descending pathways in the spinal cord. And they're called, vías ascendentes y descendientes de los tractos del cordón. Y vemos aquí los tractos piramidales, los tractos extrapiramidales, los tractos spinocerebelares y los tractos posteriores, las columnas dorsales. And so it depends on where you get injured, what happens, right? And so it makes sense to have, I don't know if you've already encountered patients with like an anterior cord syndrome, for example, which means that the anterior 2/3 of the vascularity are absent, meaning that the patient will be, are you seeing the pointer, by the way? You seeing the pointer or no?
Yes.
Yes, I can see it.
Okay, so in an anterior cord syndrome, the anterior 2/3 are gone. And so you have the corticospinal tracts are affected, so no movement, flaccid. But you have proprioception impaired because the dorsal columns are present still. And so that's the same thing with like central cord syndrome, where the injury happened in the central part of the canal, or lesión al cordón central, in which the cervical and thoracic tracts are affected more so than the lumbar, meaning that you have a central cord syndrome, meaning the cervical or the upper extremities are weaker than the lower extremities. So en una síndrome de cordón central, los brazos están más afectados que las piernas. Es un síndrome bien común que vemos en las caídas. We see this a lot in falls, where you have an incomplete injury and the patient has significant weakness in upper extremity compared to lower extremities. Okay? You all know who these people are. ¿Alguien sabe quiénes son estas personas aquí? Oh, guys, come on.
Es el profesor de X.
Well, close. Professor Xavier or Xavier. And then he is an X-Men. You are right in that regard. And who's this person right here? Who's this little man right here? ¿Quién es este?
Él es el chico elegido. No me acuerdo el nombre exacto.
Este es de
¿Bradham? No, no,
Game,
no, no es Bradham.
es Game of Thrones, ¿verdad? Este es Brandon Stark. ¿Y quiénes son estas personas de aquí abajo?
Avengers.
Ellos son los Avengers, correcto. So why am I putting all this, and as you can see with my lanyard, I like Star Wars, and if you see my coffee mug, there's, well, I don't know, yeah, there you go, Darth Vader right there. These are, I like to put movie or like I want to say social or pop culture references that involve disabilities. And these are three of them. So you have Professor Xavier, who is the leader of the X-Men, who, I mean, I'm sorry, this is a spoiler alert, but he was shot in the back in one of the movies, and that's how he became paraplegic. And so he has this wheelchair, which is, by the way, completely inappropriate. And this shows, a disability portrayal in the movies. Then you have Bran Stark, who is from Game of Thrones. He ends, I don't know if you guys have watched it or not, but in the very first episode, this little kid falls from a tower and breaks his back. And I mean, if this basically sets the tone for the whole series, by the way. And this is Hodor, who's his wheelchair carries him over the whole series, not the whole series, but everything, but like about 5 seasons of it. And these are the Avengers. And I'm putting this picture on because you have this guy. This guy is his name is War Machine or Colonel Rhodes or Coronel Rhodes, and he has an exoskeleton. This is as close as we get to real life here with the Marvel Cinematic Universe. This exoskeleton is actually pretty close to reality. Of course, it's not 100%. This is too. The ones we have now are maybe too bulky yet, and patients don't like them that much. Um, so there we go. Any questions about that? There's many. If you watch Marvel or Star Wars or Netflix movies, Harry Potter, there's a lot of disability hidden in the films, and it's really interesting to pinpoint how those disabilities, not just spinal cords, but brain injury and amputee, are portrayed. By the way, Darth Vader is a triple amputee. Luke Skywalker has a upper extremity amputation from a lightsaber. So it's very interesting. But anyway, we continue. Seguimos aquí con parte de lo que yo hago en las consultas, es ver pacientes temprano en el proceso de rehabilitación. So we see a lot of early rehabilitation consults. We see, which is, English for rehabilitación temprana. We get consulted really early in the process. And why do we get consulted? Why do we need PM&R in the ICU? Because study after study, it does show that a dedicated physiatrist, which, by the way, I should have started with this. Physiatrist in Spanish is fisiatra. Probably this is not your first Spanish talk, so I'm hoping your other speakers have said that. Fisiatra is the correct translation for physiatrist in Spanish, or médico de rehabilitación física. It depends on where you are, but in Latin America, Puerto Rico, fisiatra. So a dedicated physiatrist provides early specialized care to patients who, in this particular study, sustain a moderate to severe TBI because it improved functional outcomes upon discharge from rehabilitation. Eso significa que mejora los resultados funcionales al ser dado de alta de rehabilitación. This is a little bit of weird because upon discharge from rehabilitation, what does that mean? In this particular study, it means discharge from inpatient rehabilitation. Rehabilitation continues after that, outpatient, home, whatnot. So that's how you look at it from that perspective. Así que mientras más temprano tú como médico estés involucrado en el pronóstico del paciente, o mientras más temprano tú estés involucrado en el caso, las probabilidades de que el paciente vaya a una unidad de rehabilitación más temprano, de que pueda tener mejores resultados funcionales, aumenta. So it improves the possibility of improved functional outcomes, right? This is another early rehabilitation study. In this one, basically, early PM&R, physical medicine and rehabilitation consult positively impacts functional status and length of stay, which is also very important because you don't want the patient to stay in acute too long or kind of like figuring out when to go to rehab and such. So that's pretty important to talk about length of stay o el tiempo que el paciente está en el hospital antes de ir a rehabilitación. You want to have a happy medium there between the patient being stable and the patient going to rehab in an appropriate manner. Y nosotros los fisiatras podemos ayudar con eso, podemos ayudar con determinar cuando el paciente está listo para ir a rehabilitación. As physiatrists, we can help with that. We can kind of assist in making a decision as to when the patient can go to rehab. That's part of it. And some of you, if you haven't done any consult rotation, a lot of those consults come in, they are for what is dispo, a disposición, where we're going to send our patients, and it's pretty rewarding to kind of help facilitate that and see the patients thrive in the rehab community, in the rehab, inpatient rehab. This is another study of early rehabilitation, rehabilitación temprana. En este nos habla de cómo el fisiatra puede ayudar en otras cosas, puede ayudar en manejar esas cosas no médicas, como lamentablemente hay que hablar mucho con las aseguradoras, con los planes médicos. Unfortunately, some issues in terms of length of stay have nothing to do with medical aspect, have to do with insurance companies, has to do with doing peer-to-peers, have to do with delay because of difficulty transferring the patient because of paperwork. So we can certainly help with that. Sometimes we get called to kind of work with the insurance company or try to help our colleagues explain to the insurance companies, okay, this is why this patient needs to go to rehab. And again, that's part of how a physiatrist should know how the process works so that we can continue advocating for our patients, not just medically, but also from an insurance payer-related aspect of it. So, ¿hay preguntas por ahora? Okay. This is another topic that is very important in terms of early rehabilitation. It is when, on this one, let's go back real quick. This is about costs and lengths of stay for the acute care with patients with spinal cord injuries. In this particular study, they showed that an early admission to an SCI center was associated with short lengths of stay and lower costs. So meaning, if you have an spinal cord injury, it's better for you to get transferred to, let's say, Memorial Hermann in Houston, which is a level 1 trauma center, or UTMB in Galveston, as compared to a community hospital that may be 20 minutes faster to get into, because in a level 1 trauma center, you get more disciplines. So you have neurosurgery, you have orthospine, you have physical therapy, you have occupational therapy, you have PM&R. And so I think that's very important to kind of note that prognosis may be better if you get to a level 1 trauma center sooner. Así que esto es bien importante para nuestros pacientes que viven en áreas rurales, como son los pacientes hispanos. Muchos pacientes no tienen los recursos de estar en una ciudad y viven en áreas rurales. ¿Qué pasa cuando tienen una lesión al cordón espinal? Pues a lo mejor llevan primero a un hospital regional o un hospital de la comunidad y después se transfiere. Eso es más o menos un tiempo que se puede recuperar si se transfiere directamente a un hospital de nivel 1 de trauma. So basically what I just said was a lot of our Hispanic patients, Spanish-speaking patients, do live in rural communities or not close to a level 1 trauma center. And that's where that time frame, whether they should go to like a community hospital and then transferred, should be, we could ask that question. Of course, if they're unstable or they need immediate attention, then community hospital, sure. But if the patient is stable enough, that could transport straight to Houston or San Antonio or Dallas or Austin or whatever, that's how you go. There's also a lot of controversy in terms of surgical management and to when to do it. El manejo quirúrgico es bien importante y hay una discusión en cuándo se puede hacer una cirugía, cuándo es importante hacer la cirugía. En este estudio del 2004, this is a study from 2004. I know it's kind of 20 years old, but bear with me. It showed that early surgical treatment is beneficial in terms of reducing complications, length of stay, and hospital costs. So en este estudio se habla cuán benéfico es que el paciente reciba una cirugía temprana para reducir las complicaciones y reducir las estadías y el costo en el hospital. Pero se necesitan más estudios. So that was 2004. There is this new study, well, not new, but more recent, from 2016 that continued to show that patients decompressed early were more likely to exhibit a clinical improvement in neurologic status at 6 months and then at discharge from inpatient rehab. Patients treated early for central cord syndrome achieved significantly greater improvement in neurological and functional status than those decompressed late. Así que vemos cómo es importante esa decompresión temprana en pacientes que tienen lesiones al cordón espinal en el área cervical. Y eso pues se ha visto en esos dos estudios. So this is very important that we already have 2 studies about that. That show early decompression, meaning between 24 and 48 hours after the injury. But then it comes the issue with aging, right? As I was mentioning earlier, you have an older population that may have additional comorbidities. So it's not as easy as just taking them to the operating room. Their blood pressure needs to be stabilized. Their sugars need to be stabilized. They may have other issues happening because it's a 65-year-old that had a fall. Así que la decisión de cuándo se maneja quirúrgicamente o cuándo se opera es bien importante para determinar el futuro. So it's very important to determine as soon as possible when to operate, because the sooner in general terms, the better it is, especially for cervical injuries. And why cervical injuries? Because cervical injuries, there's a lot that could happen. Like you can lose one motor level or improve one motor level, and that's the difference between transferring and not transferring, right? So that's very important. I mean, transferring on your own, basically, or being able to grasp or hold. So that's pretty important. Y eso es bien importante en el área, cuando un paciente tiene una cirugía cervical, que estos pacientes, mientras más temprano mejor, porque podrían recuperar más control motor de las extremidades superiores. Esto es básicamente el examen ASIA. Algunos de ustedes lo han visto, se han rotado aquí o han rotado en otras unidades de Spinal Cord. Es el examen que se usa para determinar el nivel motor y el nivel sensorial de un paciente que tiene una lesión al cordón espinal. El otro nombre es el IMSCI. So this is the Asia. We're going to talk a little bit about the Asia exam, or the IMSCI exam, which is the test that we use to determine a motor and sensory level as well as completeness of the injury. It systematically evaluates all dermatomes and myotomes to determine level of injury. It develops a scoring system, which I'm going to show in another slide, that we can kind of follow up the patient as he or she continues to progress. So it's a numbers game. You add them up, and then you kind of see them as they go through the rehabilitation. This is a test or a physical exam that needs to be done several times during a patient's injury, at the beginning when they originally have it, on admission to inpatient rehabilitation, on discharge, 1 year, 5 years, and so on and so forth. It is not a complete neurological examination. It doesn't have reflexes, and it's not really validated for other conditions other than spinal cord injury. So what muscles do we test? ¿Qué músculos nosotros evaluamos? Pues usamos 5 movimientos o 5 tipos de movimientos para evaluar las extremidades superiores. So we use 5 muscle groups to evaluate the upper extremities. This is by convention because remember the patient may be laying on their back because you have to assess the patient while they're acutely ill. So this by convention was decided that are the easier muscles to test in both upper and lower extremities. Así que vamos a hacer esto en español. Lo más importante, lo que usamos más son los músculos que hacen flexión de codo, elbow flexion, en C5. C6 o C6 son los extensores de muñeca o wrist extensors. C7 son los extensores de codo or elbow extensors. C8 are finger flexors or flexores de dedo, que son el flexor digitorum profundus. T1 or T1 are the little finger abductor, which is the abductor digiti minimi. Sorry, kind of got lost there with the frame. But those are the major muscle groups or the muscle groups that we kind of test to assess for myotones from C6 to T1, which are the motor myotones we test in the upper extremities. En las extremidades inferiores tenemos 5 grupos adicionales. We have 5 other muscle groups that we test in the lower extremities. L2, L2 son los flexores de cadera or hip flexors. L3 son los extensores de rodilla or knee extensors. L4 are the ankle dorsiflexors o dorsiflexores de tobillo. L5 are the long toe extensors or los extensores del dedo gordo. And S1 are the plantar flexors of the ankle or plantar flexores de tobillo. And we get that, again, it's a convention, is we do 5 on the upper extremities, 5 on the lower extremities. And that helps us get a sense of amount of muscle testing in general for this particular patient. I mentioned the American Spinal Injury Association, which goes by ASIA. And they have this, I think most of you have seen it. It is a spreadsheet that we fill out with our physical exam and the ASIA exam in general. They have it in English, they have it in Spanish, they have it in German, they have it in Portuguese in their website. So it is free to download and you can use it. So this is the Spanish, of course, the Spanish-speaking version of it. And so it separates between the right side and the left side, derecho, izquierdo. And we test them, do the manual muscle testing on the muscles I told you about, 5 on the upper extremity, 5 on the lower extremity on both sides. And then we check for sensory, and those are called puntos sensitivos or puntos sensoriales. And we go from C2 down to S4, S5. And this is like a dermatomal distribution that we try to use for reference right here. And we both use pinprick and soft touch. So we scored it for sensory in all dermatomes for pinprick and then for soft touch. Pinprick using a safety pin, soft touch using a cotton swab, for example. And then we use this particular, I guess, framework where 0 is absent, 1 is altered, and 2 is normal. So if you have an injury up on C8, then All of these are 2, and then C8 is 1 or 0, and then everything else is 0, for example. S4, S5 is the rectal examination, which has voluntary anal contraction or contracción anal voluntaria, and deep anal pressure or presión anal profunda. And that's how we decide whether the patient is complete or incomplete. So I can give a 1-hour Spanish talk about this. I'm not gonna go into details too much about it, because if done correctly, this needs to be about 45-minute, 1-minute examination. And it has these nuances as the way you test for, in motor, I didn't mention this, but in motor you test for like amount of muscle testing from 0 to 5, including anti-gravity, with gravity eliminated, with range of motion eliminated. So the other thing we do in the acute phase is talk about autonomic dysfunction or disfunción autonómica. A lot of our patients do have other issues. They come in, their blood pressure is super low, their heart rate is super low. So bradycardia and hypotension are one of the most common autonomic dysfunction issues for acute spinal cord patients. So we have patients that were 120/80, really stable, and now their blood pressure 90/60, heart rate 50. And that's because of the dysregulation of autonomic control and the imbalance between the parasympathetic and sympathetic nervous system, depending on where the injury happened. So bradycardia is easy. It's bradycardia. Tachycardia, tachycardia. Orthostatic hypotension is hipotensión ortostática or orthostasis. Other things that can happen is thermoregulation could be affected, and patient cannot control their blood pressure or their temperature, I'm sorry. If it's too cold in the room, the body temperature is going to be low. If it's too hot in the room, the temperature is going to be high as well. So we have to kind of see it like that. A fever may not absolutely represent an issue with an infectious process. Any questions so far? Okay. So now we're going to a couple of things that we talk about in the consults that not necessarily relate to, where the patient go to rehab. We have some medical recommendations as well. Pulmonary management or manejo pulmonar. Respiratory complications remain the most common cause of mortality following SCI. Las complicaciones pulmonares son la causa número 1 de mortalidad después de una lesión al cordón espinal, tanto agudo como crónico. So even acute or chronic pulmonary complications can be the number 1 cause of mortality and morbidity. And the reason is because depends on your level of injury. If you have a high thoracic or cervical injury, paralysis of the intercostal muscles create an unstable chest wall, such that during inspiration creates a paradoxical movement and is very poorly efficient. Así que la respiración es bien ineficiente. El paciente no puede respirar bien. So what happens? If your breathing is very inefficient and your muscles are weak, what happens? You get tired. And when you get tired, you start retaining CO2, you start breathing a little bit shallower, and then you can have a situation where you need to be intubated. And that's very common. It may not happen immediately, but it may happen in the first 24 or 48 hours. So close monitoring in the ICU for cervical injuries is necessary most of the time. Checking vital capacity and ABGs are very important too. Las complicaciones más comunes, hablando en términos pulmonares, son fallo ventilatorio, atelectasis, pulmonía, ya sea por asociada a disfagia o a aspiración, efusiones pleurales, manejo de secreciones o la tos, una tos débil, impaired cough, because they don't have the intercostal muscles, they don't have the coughing mechanism as strong, so their clearing mechanism is weak, creating the situation for the things I just mentioned, atelectasis, pneumonia, pleural effusions. there's a lot of controversy right now regarding how do we manage ventilators in spinal cord injury. Our very own Dr. Koropulu here at UT Houston is doing research on to figure out what is the more appropriate tidal volume on patients, what is the most appropriate setting for ventilators. A lot of our patients come to TIER, which is when I practice, and require ventilators. And we have a weaning process or a weaning protocol to help patients as much as possible be off the vent, which is a goal of rehabilitation. So, and then other things that could be involved in pulmonary management that are separate, right? Are the presence of a complete spinal cord injury, Glasgow Coma Score, injury severity scale, associated injuries, right? So spinal cord injuries do not happen in a vacuum. Estas lesiones no pasan sola, pasan con otras lesiones. You can have a spinal cord injury, but you also can have a hemothorax or a pneumothorax from the seatbelt, or you can have a gunshot wound that hits the lung and then goes to the spine. So you have to take it in the whole context of how this works and how to best serve our patients with the recommendations about management of pulmonary management. Oops, sorry. Manejo de vejiga o manejo o bladder management. Hay tres cosas que nosotros hacemos principalmente. El catéter interno o permanente, or what we call indwelling Foley or indwelling catheter. Lo segundo es un programa de cateterización intermitente, en donde el paciente se cateteriza cada 4 a 6 horas, where the patient catheterizes every 4 to 6 hours. Y el tercero es un catéter externo, condom catheter or external catheter. Ese no nos gusta tanto. That's not one of our favorites. But it could happen. It could show up in the ICU or some of the other units that are not familiar with spinal cord injury. Yeah, most of the time in the ICU, we kind of recommend to keep an indwelling Foley in because we don't know how this is going to go. And this is the treatment of choice for a neurogenic bladder after a spinal cord injury. Jeopardy trivia here. Kidney failure was the leading cause of death after World War II because the management of neurogenic bladder was not, we didn't know what was happening. And so once we figure that out, it was treatable. Let's say you have a situation where your bladder is full all the time. There's a lot of pressure in that bladder, and we don't know. So if you keep having issues with your bladder and high pressures inside your bladder, that's going to transmit to the kidneys. And eventually you will develop hydronephrosis, CKD, hemodialysis, and you name it. So this is why bladder is very important. Manejo de vejiga es bien importante desde el principio. Anybody knows what this is? That's a syrinx. A lot of our patients develop a syrinx maybe 5-10 years out of their original injury. And it's basically loculated. You have a bunch of fluid inside the cord. And this is an MRI, T2 signal, where the CSF is contrasted with the darkness of the spinal cord. And you can see how there's fluid accumulated inside the cord, and that can cause a syrinx. Symptoms include patients being stable for 10 years, and all of a sudden they have more pain, more spasticity, more weakness. Look for that. I mentioned that indwelling Foley's, esos catéteres are like the mainstay of treatment initially. But there's a problem. Hospitals don't like catheters. Los hospitales no les gustan los catheters porque están asociados a básicamente una medida de calidad. CAUTIs, C-A-U-T-Is, catheter associated urinary tract infections, are a quality measure. that Medicare and Medicaid services, kind of the Center for Medicare and Medicaid Services kind of take that as a quality measure for a hospital. So if you have UTIs associated with catheters, that's a ding on the hospital. The hospitals want to take out the catheters as soon as possible. But in this particular patient population, this is exactly what you need to do at the beginning. So it's like an issue with the CDC, right? And a couple of our faculty members here at TR are actively discussing that and with the CDC and actively engaging in that. Manejo de intestino, manejo de vejiga, bowel management. Unfortunately, this hasn't changed in the last 40 years. There's not a lot of updates in that. We do have several options that we can do, which I'm going to go through them in Spanish. Usamos fibra para básicamente darle más forma a la excreta o a las heces. Usamos suavizadores, como es el DocuSate, para poder manejar cuán sólidas son. Nosotros usamos también agentes prokinéticos, como es el SENA, que aumenta la peristalsis. Usamos irritantes de contacto, como son los supositorios y las mini enemas, que nos ayudan con el reflejo rectocólico para poder tener algún tipo de movimiento. Y todo depende del tipo de intestino, del tipo de lesión que uno tenga. Hay dos tipos de lesiones: la lesión de neurona motora inferior y la lesión de neurona motora superior. There's two types of bowel issues here. Depends on your level of injury. One is an upper motor neuron bowel, which is an injury to the spinal cord, maybe above T10, T9, where above the conus medullaris. And then you have a lower motor neuron bowel, which are mostly found in injuries that are around the conus and below to the lumbar spine. The lower motor neuron injuries are more difficult to treat because there is no reflexes available. Patient's sphincter is open, there is no tone, so patients do tend to have more accidents. In the upper motor neuron injury, there is sphincter tone, or there's still that reflex, and that's why a lot of our patients with an upper motor neuron bowel, the suppositories work, digital stimulation works because they involve that reflexes that are present. Transit time, it's super slow after a spinal cord injury. Usually from the time you eat to the time it comes out, it's about 24 hours. For a spinal cord injury patients, it could be up to 48 to 72 hours. So something that you have to have in mind. Así que es bien importante que tengamos todas estas medicamentos disponibles, porque una sola no va a ayudar, es una combinación de muchas. These are just a few of the things that you can use. There's more newer things like Peristeen, which are like water enemas and other things that you can do, but there's no kind of like golden egg here. It's, you have to try it out, multiple things to help with that. This basically is an image of other things that could happen, in spinal fractures. Non-spinal fractures, like a clavicle fracture, they don't come in a vacuum, of course. I think I have 10 minutes left, so let's go real quick here. Este slide es para hablar de la nutrición. Es bien importante que estos pacientes tengan una nutrición apropiada, específicamente en las primeras 48 o 72 horas, porque ayuda a disminuir complicaciones, ayuda a mejorar los resultados de la rehabilitación y disminuye la estadía del paciente en el hospital. So initiating feeds after 48 to 72 hours can reduce complications, improve outcomes, and decrease length of stay. Another issue with nutrition is dysphagia. A lot of our patients have that initially, especially if they have a cervical injury. Y se ha notado que estos pacientes 7% sufren de disfagia severa, porque por la edad, por la parálisis y por la presencia de una traqueostomía. So if you have an older gentleman, for example, that has a cervical injury, and on top of that has a trach, there is a severe risk of dysphagia, and that's something that you have to plan ahead with the patient and the family. And most likely they have a trach, they're probably on a ventilator, at least at the beginning. Y este estudio es bien importante, diciendo que si tú tienes una combinación de una traqueostomía más cirugía anterior, an anterior surgical surgery, va a haber una posibilidad bien alta de desarrollar disfagia, aproximadamente 48%. So basically 48% of people that have a trach and have had a cervical anterior surgery may develop dysphagia. So very, very important to take that into consideration. The lowest hanging fruit is skin and recommendations to treat the skin or la piel. Turning them, resting splints are very important. Something else that we talk about is prophylaxis para thromboembolismo or DVT prophylaxis. We mostly use heparin or Lovenox. And we recommend the use of graduate compression stockings o medias de compresión, que nos ayuda con ese movimiento en las piernas. It helps us with some of that vascular movement in the lower extremities. There is no recommendation for routine Dopplers unless it's absolutely necessary, or there's a contraindication for pharmacological. Let's say they have a spinal cord injury and a subarachnoid hemorrhage, and pharmacological prophylaxis is not recommended. So we can do Dopplers and then consider doing an inferior vena cava filter. So, and I guess this is the last slide. I'm gonna talk. It is important if you're bilingual or you speak Spanish or English or French or whatever, to explain the rehab process in a lot of our patients. They don't necessarily understand everything. They may be lost. They may not still, talk about the severity of the situation. And that's where if you know Spanish or whatever language, and you can kind of explain to them what's going on, because a lot of our patients, they don't know what's going on until you go and talk to them and talk about what's going on or what the rehab process is and how to navigate the system and navigate expectations. So every time you go see a PM&R consult, whether it's for a brain injury or a spinal cord injury or some traumatic injury, catastrophic like that, you have to be prepared to talk about all these things, whether in English or Spanish or whatnot, because the family, they will have a lot of questions for you. And don't assume that the surgeons or the ICU team has already spoke to them about, their injuries. So, and learning a second language, or especially in Houston, which has a very robust Hispanic population, is going to help you a lot. Así que uno trata de ver estos pacientes y explicar lo mejor que pueda, porque hay unas expectativas de recuperación, unas expectativas de cómo funciona el sistema que la familia y el paciente tienen que abordar cuando uno llega a ese nivel. Así que basically this is it. This is what we do. Early involvement in rehab services, not just the physiatrists, but also the physical and occupational therapy and the speech therapy. And we went through a lot of things that we do in the consult, but I didn't talk about spasticity or pain, because those are very important topics as well, and probably need another Spanish talk here. But we are very important in the setting of acute injuries and also in the chronic. So I feel like we do have a place in the ICUs, and we help. There's a lot of studies coming from Johns Hopkins and Mount Sinai that says that our involvement early on is certainly important in all those steps that we talked about. Así que muchas gracias por el tiempo. Ya son las 4 más o menos. Así que le agradezco que me hayan dado esta oportunidad, y si tienen preguntas o si tienen alguna pregunta en términos del lenguaje o de qué palabras usar, if you have any questions about anything, including how to say stuff, just I'm here. Let me know. Thank you so much.
Muchísimas gracias, doctor Frontera. So now I think we can open it up to questions if people have questions.
I had a question. Vi que usted dijo la palabra cordón para describir el parte entre los huesos, y otras veces vi que otras usan la palabra médula. ¿Que los dos son correctos o hay uno que es preferido?
Los dos son correctos. Cordón, así fue si uno ve en español, son como dialectos distintos, como, it's like going to the Midwest or going to the East Coast compared to people in California or Texas, but like the exact same thing. So yo puedo decir cordón, and I'm talking about spinal cord, and my colleague in Mexico can say cefalorraquídeo or médula. And it's the same, we're talking about the same thing. So you can say, uno puede oír trauma raquimedular, trauma cefalorraquídeo, y trauma al cordón espinal, y probablemente all of them mean SCI, spinal cord injury. Así que no hay una sola manera de decirlo. Yo lo digo como lesión al cordón espinal porque así fue como yo lo aprendí, pero puedes decir como médula, trauma medular. Pasa que yo digo médula más bien, para mí médula es más bone marrow. Solamente como yo lo aprendí.
Gracias, perfecto.
I have a question. So for maybe some of for myself and maybe some of the other people who are on this call who use translator just because I'm not fully fluent in Spanish. I'm comfortable having some conversations, but not all, especially when going into depth about these sort of topics. Can you give some advice to us about working with Spanish-speaking populations and maybe using translators or some tips that you just have from experience?
Well, I think in general, like depends on your level of how comfortable you are. Translators are important always, of course. I use them. I mean, not all my patients are Hispanic or English speaking. There's a huge Vietnamese population here in Houston, for example. So of course, I use them. My French is not that great, so I use them for that. But it's how comfortable you are, and even if you know a little bit of Spanish, your Spanish-speaking patients will know it and will be thankful for it because not everybody will come in and nuanced and speak to them in Spanish. They will assume, oh, they don't understand, they'll go away. So even if you know just a little bit of Spanish, patients for the most part will be very grateful for that. Now, if you don't feel comfortable saying something, then yes, of course, a translator. Right now, we use both in-person translators and one of those rolling iPads that show up there. So both are fine, and we use them to bring particular important information if they need to know something, if you want to make sure that you know it. But even if you know 3 words in Spanish, don't be afraid to use them with your Spanish-speaking population because they'll be very grateful for it.
Thank you. Any last burning questions, anybody? If not, all of us would just like to thank you so much for being here, Dr. Frontera. And hopefully we can all stay in touch and maybe have you back here again. The presentation was awesome.
No problem. Muchas gracias por la invitación, and I appreciate it so much. Thank you, and happy holidays, Feliz Navidad, Happy New Year.
Thank you. Happy holidays.
So
bye. Thank you.